Dear juniors and colleagues, hi, this is Dr. Semanchal Goel, and I just had a conversation with the Chief Medical Director of my organization, to which he said it's a patient's right and it's the duty of a doctor to explain him what astigmatism if he suffers an astigmatism more than 1 diopters in the steep axis. So you should always explain the possibility of getting a toric IOL and what astigmatism is if the patient has. Even some doctors are implanting toric IOLs in astigmatism more than 0.75 diopters. So the golden tip which I would like to stress what I am doing right now in the video is a dry cornea is your best friend for toric IOLs. A dry cornea is your bestest friend in implanting a good toric IOL. When you mark 0 to 180 degree horizontal meridian on the slit lamp, make sure the cornea is dry. Once you mark them, once the eye cyclo rotates in the operation theater in front of you, make sure when you are marking the axis to just dry that cornea out with the Vexil sponge or a swab stick, just like I did. So I have slowed down the most critical part of the video for your discretion, and we'll be putting this 4 haptic IOL in this patient who has 3 big complications in his eye already. Still he chose to get a toric implant. The patient is a high myope, the patient has end stage glaucoma, and there was a little bit of corneal degeneration, if I would add. And yes, the patient had 3 diopters of astigmatism. We have to implant this IOL at 120 degrees, and the best way to move about is, the best way that I like to do is like I'll make a superficial abrasion at 120 degrees in the cornea, abrading the epithelium, abrading superficial 10 or 20% of the stroma. And you can see I have a 26 gauge needle in my right hand and the toric marker in the left hand, and yes, I will give a superficial cut in the cornea at 120 degrees straight towards the center of the cornea. This is the most critical step the newbies need to learn. 0 to 180 was also marked with superficial cuts and then applying the dye, and in the OT itself we will just abrade the cornea at 120 degrees on the right hand side, and the same goes for the left hand side. And that's it. We are done on the right side, and there are really golden takeaways from this video, and I'll be sharing you how difficult this case was and the final visual outcome of the patient. So we are done on the left side as well. As you can see, the superficial 20% to 30%, even 30% of the stroma is abraded, but don't worry, it's not going to have any surgical ramifications in the post-op result. There will be no problem at all, but it is very important for a surgeon to visualize the correct axis and placing the IOL in the right axis. We don't want any post-op rotations. As you know, the first 24 hours are very critical for a toric implant because the maximum chances of rotation are in the first 24 hours of the post-op period. And I'm happy with the marking that I have done, but these abrasive lesions and these marks are not going to stay. So under visco they will disappear. So I am going to use a dye pen to just touch the mark that I have made, and it takes the dye in itself by a capillary action. As you can see on the left hand side, the dye has gone through and through in the abrasive crept that I just made with my needle, and this is the best way, and I have found some really good and amazing results. Even I have done my cases on Varion as well and Callisto as well, but a foolproof system of marking accurately gives us the same results as that on Varion or Callisto. So yes, we are done with the marking. I'm very happy with the marking that I have made. Just to give you some details on the patient is 70-year-old man, and yes, the patient is an NRI, and he is on psychiatric medication for some reasons. The patient had a myopia of around 12 diopters with 3 diopters of astigmatism. When I look at the fundus in the preoperative period, the patient had 0.9:1 of cupping. I explained him everything. I explained him guarded visual prognosis, post-op surgeries. We got his fields done. There was field loss on 10-2 HFA. And I explained him his pre-op vision was around 6/60. And I was shocked to see the post-op results. I'm going to tell you the post-op results later on this video. So kindly stick with me. We have a lot of good things to discuss related to astigmatism. This is my first video of Toric IOL implant in my channel, and you're going to learn a lot of good stuff. And as the cornea takes up this dye, I can safely put some visco over the corneal surface. We can clearly see the 0 to 180 degree meridian and the 120 degree axis on which I have to implant the IOL. If you notice very specifically, and if you have an eye for detailing, you'll notice that the 120 degree axis is not marked perfectly, but it's okay. We are going to implant the IOL. We have a fair bit of idea where we have to implant that IOL now. And the location of the side ports and the main port is also very, very important in Toric IOLs. Toric IOLs are special because they are challenging in a lot of ways. You have to make a decently small sized rexes, that is around 4 to 4.5 mm, just to decrease the post-op rotation of the IOL. I like to make a small rexes in these patients because I want the anterior capsule to just hold that IOL in the post-operative period. I don't want the anterior capsule should be bigger than the optic of the IOL, so that the IOL gets a chance to move around and tilt and turn in the bag. And yes, we are done with 2 perfectly opposite side ports, which are very important for astigmatic neutralization. And we'll go ahead with the staining part. We'll be putting some air bubble and the dye, the usual steps. Just notice my rexes. Alright, and we'll go ahead with the normal speed and staining the capsule, making a small rexes. I had chosen an IOL specifically for this patient because I found that the 2 haptic design of Toric IOLs, I like that design, but I love a 4 haptic design, especially in Toric IOLs. I'll share a secret with you what is so special about 4 haptic design in Toric, especially in Toric cases. I found it really good. The results have been really great for me for 4 haptic design in Toric implants. And just egressing that air bubble, and we'll go ahead with the rexes part now. And yes, I've made a cystitome from a 26 gauge needle. I've asked my OT assistant to just push off those bubbles from my field of view, and we'll go ahead. Considering the grade of the nucleus, I felt that it's better to have a 5 millimeters of rexes in place of 4 to 4.5 because the patient is a high myope and anterior chamber fluidics also matter. So I have made a 5 millimeters of rexes because it's safe in a cataract that is around grade 3, between grade 3 and grade 4. I'm going ahead with the hydrodissection and just putting that nucleus back into the bag when it prolapsed. As you can see, when I pushed the visco, the anterior chamber just deepened out. This is a sign that the patient is a high myope. You can even see the iris, and the chances of iris retropulsion syndrome are also very high in these patients. So you should also know, if you encounter lidars, how to just counter that. And if you're new to the channel, I would like to request you to kindly like, share and subscribe my channel, because I share these wonderful videos on special scenarios in cataract surgery. I'm a phaco-refractive surgeon, and it would help my channel grow if you like, share and subscribe. Share this video with your friends who are new to cataract surgery and are scared to implant a toric IOL. The toric IOLs, yes, they are demanding, but they are easy. With practice, you can just practice toric marking on your monofocal cases. This is one of the tips that I got from my friends, who's a brilliant surgeon himself. He used to practice toric marking on all the monofocal cases he used to operate, and in no time he got proficient at marking, because marking is very, very critical in these cases. From this view, you'll see the corneal surface is a mess, but don't worry. And we are going ahead with the phaco part. I have voluntarily sped up the video for my audience to not get bored with the usual steps. The cataract is around grade 4, grade 3 and grade 4, and yes, the half heminuclei is gone, half is left. I have asked my OT assistant to switch to continuous mode with decent power, 50%. I rarely go beyond 70 or 80. In very hard cases, I make it 70, 75, but not more than that. And yes, the bag looks beautiful. The fundal glow is great, and the pupil has come down. It's yes, but putting on the visco, the bag inflates and the iris goes to its normal position. You can see minimal bleeding in the anterior chamber from iris. These myopic patients generally bleed in the anterior chamber, but it's going to stop. I have put some visco to tamponade the bleeding in the anterior chamber. Visco works great for tamponading those bleeders. If you ever injure the iris during your phaco, put that visco, wait for 2 minutes, it's going to tamponade the bleeder really well. Nothing else works. If you put visco, still the bleeder is bleeding, you can put some ADR. You can try ADR. ADR also works fine by vasoconstricting the bleeder. But yes, visco works for 90% of the cases. And yes, we are done with the phaco part. We have inflated the bag looks clear, and we'll go ahead implanting a 4-haptic IOL. So I am implanting a pod eye toric IOL from the company BVI. It's an Austrian company, and it makes beautiful lenses for astigmatic patients. And this is a 4-haptic design. And the main point to note about this IOL, the beautiful part that I noted, is the IOL optic is around 11 millimeters in diameter. If you are a proficient surgeon, you must be knowing that the most of the IOLs from Johnson & Johnson and Alcon are around 13 millimeters in diameter. And I beg your pardon, the haptic to haptic distance would be 13 mm, and the optic part is around 6 mm. So in this IOL, the haptic to haptic diameter is around 11 mm. So this IOL is very, very easy to rotate in the bag. For toric IOLs, you specifically need rotation in the bag, and this IOL offers great rotation for the surgeon. And what's even better is you can rotate this IOL in both the directions, either clockwise or counterclockwise. But in C-loop designed IOLs, you can only rotate them in the clockwise axis, making rotation a tricky part in those IOLs. So this is what I loved about this IOL. This is a 4-haptic design, yes. 11 millimeters haptic to haptic distance, yes, which makes this IOL a little bit smaller than the actual bag size, which makes it easier to rotate clockwise and counterclockwise. So you don't have to go 360 degrees full rotation to align it again if you miss the important axis of implantation. And just like that, I am just pushing out all the visco into my aspiration cannula, and I'm making sure the IOL is well placed. And yes, one piece of advice that I would like to share is BVI IOL markings on the IOL are a little faint. They are on the fainter side. Johnson & Johnson has really crisp 3 dots markings on the IOL surface, but they are a little faint, so it would be tricky for you guys to see it in the video. I was able to visualize them easily in the operating microscope. I have a Zeiss Lumera microscope. It was really easy for me to spot them, but you will have a little difficulty in the, but yes, you can see the optic haptic junction. Mostly the toric markers are placed on the optic haptic junction, and you can see, I'll inflate the bag for you. The axis is perfectly aligned with the 120 markings that we have made pre-operatively. So it was a beautiful fun case for you all to see how a toric implant is done. A 4 haptic design of the IOL gives excellent rotational stability in the bag, making those beautiful outcomes. The patient, even with a CDR of 0.9:1, had a visual outcome of 6/9. I implanted another toric IOL from the same brand in his other eye, and he got 6/9 vision in the other eye as well. I kept him on anti-glaucoma, and the patient is doing really well. He was very happy with the visual results. He had already taken a guarded visual prognosis, but the patient was smiling in the post-operative period. That's all from my side. I hope you like my stuff, and this is another fun case about the ABCs of a toric IOL implant. Hydrating the side port and the main port. Let's call it a day. I hope you like my videos. Kindly like, share and subscribe. Thank you.